Okay, we should be all set. Welcome back, clinical problem solvers, to another Rafael Medina subspecialty episode. We're focusing on one of my favorite subspecialties, rheumatology, today. And we have some incredible case presenters and discussants from Northwestern today. And so I'd like to ask them to introduce themselves to you guys, and also one thing at the end of their introduction that they like to do outside of medicine. So we can start with Anu.
Hi everyone, I'm Anu. Thank you all so much for having me today. So I'm a first-year rheumatology fellow here at Northwestern in Chicago. I did my internal medicine residency at U Chicago North Shore up in Evanston, and I did medical school at the University of South Alabama in Mobile, Alabama. When I'm not in clinic or in the hospital, I really enjoy painting, tending to my houseplants, or biking on the lakeshore.
Thank you so much, Anu and Olive.
Hey everyone, it's really great to see you all, and thank you so much for having me. I'm a first-year fellow, like Anu. I actually did my internal medicine residency here at Northwestern, and I did my medical school at University of Illinois. In my free time, I really love playing board games, trying out new restaurants, eating, not cooking, and of course, just hanging out with my friends.
Oh, awesome. And Anisha.
Hi, everyone. I'm Anisha. I'm the program director for the Rheumatology Fellowship here at Northwestern. I run the Vasculitis Center. I love medical education. I like vasculitis. Outside of that, I do pottery. I like pottery a lot, and I like traveling.
Oh wow, so we're gonna have like discussions about restaurant eating and pottery, and I'm really excited to get into that. But I know there's a really exciting case that's been prepared today. And so Olive, if you would like to take it away with the first aliquot, and Vinny, once you share your screen, we can get started.
Okay, so let's get started. Our case here, we are going to be in the hospital. We have a 69-year-old female with a past medical history of hypertension and recurrent strokes who presented to us with behavioral change and a global decline for the past month. So a lot of the history was actually provided from her husband, who was at bedside. And he said that for the past few weeks, he'd noticed that she was less interactive with him, less willing to kind of talk with him. Normally she's pretty, go-getter, very outgoing, very friendly, and has just been very quiet, and using very much like one-word sentences overall. In terms of her ROS, she didn't endorse any fevers or chills, no chest pain. She didn't have any shortness of breath, no cough or anything like that. No abdominal pain, suprapubic tenderness, urinary symptoms like dysuria or nocturia or increased urinary incontinence. She didn't endorse any kind of nausea or vomiting. And then overall, of course, in our rheumatic cases, no joint pain, new rashes, or photosensitivity.
Okay, thank you, Olive. So it sounds like in this woman with kind of recurrent strokes and altered mental status, Anu and Anisha, how are you guys thinking about this really altered mental status case from a rheumatologic lens? I'd love to hear your thoughts.
Well, I can do sort of like a broad scope like thing, and then I'll have Anu go into the rheumatologic piece. So obviously, when you have somebody with a history of strokes, we're a rheumatology group, and we're going to be talking about rheumatology, but you still want to obviously keep a broad differential because a lot of things can be going on in these patients, even if they have a prior history of a rheumatologic disease. So things that I would think about here off the bat would be potentially some sort of recurrent strokes. Like Parkinsonism, metabolic syndromes, hypothyroidism, depression. And then, of course, there are a lot of autoimmune diseases that can also have some sort of mental status changes that are associated with it. But you do want to keep sort of a broad differential, right, with infectious, toxic, metabolic, and neurologic potential phenomena as well. Anu, what do you think about rheumatologic options?
Absolutely. So, I totally agree. I think the differential at this point really could be so broad, but there certainly are a lot of rheumatologic conditions that, can affect the brain and can cause behavioral changes or altered mentation. Immediately thinking of some of the things that come to mind. I think of certain, vasculitides that can affect the CNS. I think of, autoimmune encephalitis or, autoimmune dementias that can be progressive. I think of things like, lupus, which can affect the central nervous system as well. But really, it could really be anything at this point.
Thank you guys so much. Yeah, I love the approach to having a very broad kind of open differential. I feel like a lot of rheumatology often starts in the internal medicine and neurology space, very, very broad differential to start, but making sure that like you guys have a slightly subspecialized lens with which you can already start to think about rheumatologic causes that influence the kind of neuropsychiatric axis. So Olive, I'd love to hear a little bit more about the patient in your next aliquot.
So next thing for her in terms of her past medical history, I had mentioned that she had strokes in the past. Her first stroke was actually in 2013, and this case was actually taking place this summer. Her first stroke in 2013 was in her right internal capsule, and then she had another stroke about 2 to 3 months prior to her current presentation, and that was in her left internal capsule around her thalamus. Around that time, her presentation were memory deficits and just poor word finding. She also has a history of hypertension and glaucoma. In terms of her social history, she's actually a special education teacher and still currently working. She's married and has 3 children. She's never had a miscarriage before. She denied any kind of tobacco, alcohol, or drug use. Her family history was largely not really contributory to her overall presentation. And then in terms of allergies, she didn't have any allergies at all. And then her medications, she was on amlodipine for her blood pressure. She actually was supposed to be on aspirin, just a baby dose, 81 milligrams daily, and atorvastatin daily. But her husband actually said that he had held the aspirin and atorvastatin because at home her blood pressures were high from his perspective. So he was concerned that maybe the aspirin and the atorvastatin were playing a role in that.
Awesome. And Olive, do you mind giving us a little bit of the physical exam and the vitals just to round out this kind of initial evaluation?
Of course. So for her vitals, her temperature was 101. Her heart rate was 87. Blood pressure 135/73. And then her oxygen, she was sat in about 92% on room air. Generally, she was in no acute distress, but she did appear very tired and fatigued. Her sclers were white. She didn't have any like lesions or sores in her mouth or around her nose or her ears. Her mucous membranes were moist overall. She did have these like hypopigmented patches on her scalp with residual scarring. For her cardiac exam, she was regular rate and rhythm. We didn't appreciate any murmurs, any murmurs or rubs or gallops. For her pulmonary exam, she had normal work on breathing on room air, and she was cleared auscultation bilaterally. For her abdominal exam, she wasn't tender. She didn't have any garden, any rigidity. And then for her extremities, she was warm and well perfused. She did have some non-pitting edema in her right lower extremity. And her skin, we didn't appreciate any rashes at all. Psych-wise, she had a very flat affect. She responded appropriately to questions, but it was just very minimally interactive and also really slow to respond. For her neurological exam, she was ANO times 3, but on her 3-word recall, she was pretty much 0 out of 3. She could remove all of her extremities without any difficulty, and she didn't have any neck rigidity. For her MSK exam, she didn't have any joint effusions that we could appreciate, no tenderness to palpation in her joints, no warmth or erythema. And then her range of motion was intact in her upper and lower extremity. Her sensation to light touch was also intact in her upper and lower extremity. And then her strength exam, upper and lower extremity flexion and extension were 5 out of 5. So really no abnormalities from that standpoint.
Thank you so much for that very comprehensive physical exam. And so, Anu, I'd like to come to you first, and I'd like to hear from you how you're sifting through some of the more fleshed out parts of the history, including the past medical history and the medications, and how that alters, if anything, your initial very broad differential.
Absolutely. So thank you for all of that extra information. It definitely kind of changes a couple of things that I was thinking, or makes me lean towards some things more than others. So definitely we see that she does have a pretty significant CVA history. With regards to her medications, it's interesting that her aspirin and statin have been held for some time, just thinking back to kind of general medicine things. Moving on to her vitals, the thing that really stands out to me here is the fever. With regards to her exam, given that she's, presenting with these behavior changes and global decline, I am particularly interested in her neurologic exam. Her strength and sensation appear to be largely preserved, but looking at this, it seems that her memory is somewhat impaired, which is interesting. Let's see. Since we're here as well, I will comment on some parts of the exam that I would focus on as part of a rheumatologic evaluation. It seems like she, definitely is a bit fatigued. And she does have these interesting scalp lesions that, almost seem like they could be something like a scarring alopecia, or even something like psoriasis or a fungal or alternate dermatologic condition. I think I saw that she has no, oropharyngeal lesions, which would include things like oral ulcers. She notably has no rashes. And then with regards to her MSK exam, I don't see any gross abnormalities sticking out to me. So it seems like from that standpoint, things appear to be largely normal.
Thank you, and thank you for highlighting those very kind of specific room-specific physical exam findings that you were looking at. Dr. Dua, I wanted to come to you for some of your expertise, given if you had been called on consults, given you are on consults right now, about a patient like this, knowing that they're altered and might not be able to give you a very comprehensive history or timeline, what are you looking for specifically in the physical exam more generally? And then do you have any specific comments on some of these findings that Anu had pointed out?
Yeah, so there have been some great comments and thoughts also just in the chat. So I'll just point that out. I'm loving the ideas. But I think just focusing on the exam and sort of the history and narrowing things down. Of course, the stroke history, along with a little bit of a low sat, and then that non-pitting edema in the right lower extremity would make me think about clots, right? So antiphospholipid or other sorts like sources of clot. And with the fever, of course, you can have cardioembolic phenomenon, you can have other infection, because a lot of people will have sort of unrecognized, they can't give you a great history themselves. So they can't necessarily, if she's not able to do recall, she might not be able to tell you. I think on her review system, she said she didn't have fevers, right? But she does. So she might not be able to express exactly what she's feeling symptomatically. So I would also still think about things like, either UTI or a pulmonary infection or something where there's just a low grade, maybe viral infection, something going on that she's not being able to pinpoint necessarily. So it's still reasonably broad. Of course, those hyperpigmented patches, I would like to take a look at those and to get a better sense of what the quality is, how long they've been around, and get more of that history. But it also does highlight the importance of relying on other people. So she's lucky that her husband is with her, and so you're able to get a little bit more of that story from them. We tend to do really thorough physical exams anyway. So, that does help when you have a limited history to look into those things like you can still assess whether someone has effusions or good range of motion passively, at least, using your physical exam. So I don't recall the question, but those are my thoughts.
No, exactly. And I think one of my more specific questions around this, as somebody who's also learning the rheumatologic exam from scratch, is we often look at joints very closely. And so any particular thoughts on what like the joint exam that was done, what the findings are there, and if that guides you in one way or another, or how you're tying that into kind of this altered mental status picture.
I mean, so, a lot of different underlying rheumatologic issues can have, first of all, neurologic involvement, but also have sort of vasculitic manifestations. And so those are things you're thinking about with somebody who has mental status changes potentially in a rheumatology space, or again, antiphospholipid and stuff like that. In terms of a joint exam, you're really looking for patterns, right? So is this a monoarthritis? Is this a oligoarthritis? Is there a polyarthritis? Is it inflammatory seeming or is it non-inflammatory seeming? That's not necessarily stuff that you can, I mean, if the person was able to communicate with you, you might be able to tease some of that out by questioning, but of course, she might not be able to tell you, I have, an hour of stiffness in my hands in the morning and it gets better with activity, which would, of course, be helpful in terms of thinking more along an inflammatory arthritis process or something like that. So for really focusing on just exam findings, with the fever, there's no signs here of like overlying warmth or severe range, like pain with short arc movement or range of motion, which would make you think about like septic arthritis or something like that. Gout and CPPD and other inflammatory types of arthritis like that, like crystal arthritis, shouldn't necessarily be associated with mental status changes. We mentioned here the synovial thickening on the right second PIP. We often think about like symmetric small joint involvement in things like rheumatoid arthritis, but and the PIP can kind of go into any category, whether that's like osteoarthritis or rheumatoid or an inflammatory arthritis or a lupus arthritis, a psoriatic arthritis. The PIP is kind of the tricky one that can kind of go in all of the different patterns. But you're really looking for sort of joint involvement. Is it hot? Does it have those features of inflammation? Or is it more like of a mechanical non-inflammatory process? And then what is the pattern? And does that help sort of move you towards more of a peripheral process or axial processes? Anyway, this person, it's a little hard to tell again with the limited ability to get a full history, but this synovial thickening on the right second PIP doesn't give me much. It could really fit into a lot of categories.
Yeah, so it sounds like still encompassing a lot of the broad overarching rheumatologic conditions. And then before I ask Olive to give us a lot of the laboratory data, Anu, is there any like particular labs that you would be asking us for as the primary team if you were to see this person on consults?
So, to start off, I definitely would want to see, some of the basic labs like a CBC and CMP. I'd want to see if she has, any signs, on her labs of an underlying infection, something like an underlying malignancy, something that would point me towards, there being an inflammatory process going on. So something like inflammatory markers would be helpful as well. And then given that she's presenting with this, global decline and these neurologic changes, I certainly would consider, an infectious workup. So some of your basic things like a UA, potentially things like a chest x-ray, and then could even consider things like a metabolic workup, like a TSH, B12, things like that, just to start.
Awesome, thank you. So ask and you shall receive. Olive, what were some of the laboratory findings?
Okay, so starting off with the CBC, her white blood cell count was 2.9. Her hemoglobin was 12.2. Her platelets were 126 and her hematocrit was 37. Her sodium was 141. Her potassium was 3.7. Her creatinine was 1.08 and her baseline was usually around 0.7. We had a bicarb that was 26. Her magnesium was 2.3. Calcium was 8.8 and her random glucose was 142. For her liver studies, we have her AST at 21, her ALT at 10, her ALP or alk phos at 63. Her total bilirubin was 0.5 and her albumin was 3.5. We also got a couple of other studies, TSH, which was 4.51, which reflects to a T4 that was 0.43. And something actually that we also got was vitamin B12 that was 1247. And I don't know if you guys wanted some other studies, but for the chest x-ray, we also got that, and that showed like patchy bilateral basilar airspace opacities.
Yeah, and then Olive, if you wouldn't mind sharing a little bit about what happened to the patient in the interim while these like diagnostic studies were being obtained, and any like initial imaging.
So while the studies were being obtained, because of the chest X-ray that showed the bilateral patchy airspace opacities, plus the fever that she presented with, there was some concern that she had a pneumonia component to this, especially like Dr. Dua said. We weren't really sure if you could trust her history all the way. Maybe she had been coughing, but it hadn't been caught. So she was actually just started empirically on ceftriaxone and azithromycin to just cover some kind of a community-acquired pneumonia. And then she was also given some fluids just because she didn't have dry mucous membranes, but there was a lot of concern that, is she a reliable historian, just given how much she had globally declined. And that's kind of where things settled in and for her at this point.
Okay, so some initial infectious management. I'd love to hear from the two of you what you're thinking with all of this new lab data.
I would like a little more. I mean, so the creatinine was elevated. Do we have like a urine or a urine culture? And then, those inflammatory markers that Anu had initially mentioned, urine tox, any of those types of things.
So we did get a urine tox that was negative, and then her urinalysis actually came back with her protein at 30. Her glucose, ketones, and bilirubin were all normal. Her nitrites and leukocyte esterases were negative. She had a little bit of red blood cells, just 0 to 2. White blood cells were 0 to 5, and then she didn't have any bacteria. And then for her inflammatory markers, her ESR was 39, and her CRP was 7.1.
And then I guess the other stuff that, I mean, there's a lot of interesting information here, right? Like with the low white blood cell count, the low platelets, the elevated creatinine, normal transaminases, TSH, B12 all look okay from a metabolic, endocrine vitamin deficiency angle. And then the 30 of protein, I would want to follow that up with a little bit more to figure out what the spot PC would be, or a 24-hour, if that was possible. Inflammatory markers are mildly elevated. I mean, we think about, SED rates and when they're elevated, but rule of thumb, it does increase with age. And so you usually want to take the age and divide it by 2. And that's actually kind of around the normal range for somebody. So it's elevated, but not crazy. And then, of course, kind of differences between SED rates and CRPs. And we can get into that. But the CRP is elevated there. So that does make you, again, it could go along consistent with an infectious process that she's being covered for. But I would want to know more specifics on some of the infectious possible etiologies, of course, like follow up on that. But I still think other things could be going on. So that's my initial thoughts. Anu, you go ahead. What do you think?
Absolutely. So the things that really stand out to me are these cytopenias. Hard to say, what's really driving those. We do see a little bit of this elevation in her serum creatinine. And then on her UA, the presence of proteinuria. And then I think you said like a few RBCs potentially definitely is, scary for, renal involvement of some underlying process, which in the setting of these slightly elevated inflammatory markers and the fact that we're here maybe worries me a little bit for an underlying autoimmune process. And then the chest X-ray findings are concerning as well, and are suggestive of like an underlying pneumonia or something, which could explain some of these findings, but doesn't explain everything. So I think there may potentially be something else going on here too.
And Olive, do you have a differential on the white blood cell count?
For the white blood cell count, I don't have a differential listed, unfortunately. From what I can recall from her case, she didn't have any abnormalities on her differential.
Okay.
Yeah.
So rare for like a person who's not super immunocompromised to have an infection with a low white blood cell count. Of course, it can happen in some cases, or, but you're thinking about also marrow disorders, right? Hematologic issues, problems with marrow production that are causing this. The hemoglobin's not that low, but there are certain autoimmune etiologies that do make you sort of perk up when you start thinking about leukopenia and thrombocytopenia. Also with mental status changes, this doesn't seem super severe, but TTP is also something that would be on the differential, right, with low platelets and some mental status changes and a bump in her creatinine. But there's more information that we can probably get.
Yeah, and Dr. Dua, I was wondering if you could comment, you said that cytopenias begin to like open up a rheumatologic differential, like what are some of the like kind of overarching hallmarks that you think about, especially with the modifiers of like elevated inflammatory markers and like this creatinine bump?
Yeah, so lupus definitely and Sjogren's are two that we really often think about when we see leukopenia. Like most of our other like inflammatory arthritides or myositis or vasculitis isn't particularly associated with low white blood cell counts. Of course, there can be cases, but when you've got low platelets and low white blood cell count, when you're thinking about the connective tissue disease realm, those are probably the top two that would come to mind.
And then you also mentioned like some more specific infectious labs that you were thinking about. I'm curious, like what other labs would you add to what's currently gathered? And I open that up to you too, Anu, like what other data are you kind of looking for in the meantime, and any imaging in addition to like those more specific labs?
Absolutely. So, I think we do have a lot of valuable information here, but, I would want things potentially like blood cultures. There are a lot of infectious processes that can cause, mental status changes. So things like, syphilis, like neurosyphilis is something that comes to mind. I would potentially test for something like HIV. And then with regards to imaging, in this patient that does have a pretty significant stroke history, I probably would want some updated brain imaging just to see what was going on and evaluate potentially for, an acute stroke or some other type of process if there was, an intracranial lesion.
Awesome.
Yeah, I agree. Brain imaging would be there, and then consideration of an LP, depending on what else is going on, would be things to definitely consider, along with the stuff that you guys have already sent off in terms of infectious stuff. Trying to think what else. I'd probably get an phospholipid antibody panel also, because that can cause, a lot of these symptoms and isn't specifically associated with leukopenia, but it's associated with lupus, and also low platelets can happen with that as well. So.
Okay, Olive, let's hear what further workup this patient got.
So for the further workup, we got some infectious studies. We got blood cultures, Legionella and strep, just because of the questionable pneumonia. We got a syphilis and a negative, syphilis and an HIV, which were both negative. Her urine culture didn't reflex, but we just got a separate urine culture that didn't, her urinalysis didn't reflex, but we got a separate urine culture that didn't show any kind of infections. And then we also got some brain imaging. So we started off with a CT brain that didn't show any acute intracranial hemorrhages. It did show like a maturing infarct of her left internal capsule and her anterior thalamus. And then we followed that up with an MRA brain MRA brain and carotid, which was overall unremarkable. Was just basically showed a stable, like moderate short segment of stenoses around like her posterior communicating arteries. However, we got an MRI brain that showed two small infarcts in the medial right temporal lobe, and then that known chronic infarct in her left internal capsule.
I feel like there's always a twist with imaging. It's hard not to sometimes be surprised when cases get complicated by the imaging. So yeah, Anu, I'd love to come to you first and hear what your initial thoughts are on some of this new data that we've gotten, including some of your negative infectious labs, and then we'll turn it over to Dr. Dua after.
So definitely, great that, some of the initial infectious studies, don't seem to be too revealing, which is wonderful for the patient. I'm definitely intrigued by these two new small infarcts in the temporal lobe and internal capsule. I'm not entirely sure if these infarcts would necessarily explain everything that's going on, especially with the lab derangements. But it is interesting that she has such a significant stroke history and does appear to be having acute stroke. So this brings to mind certainly things like APLS or other, underlying etiologies as to why this could be going on. Very concerning for sure.
Yeah, I mean, I think her husband had held the aspirin and the atorvastatin as well. So of course, just regular strokes are a possibility. she's got but that doesn't explain the cytopenias. And then she's got, these 2 new infarcts. And sorry, did you tell us the quantification on the protein for the urine? I mean, it's good that there's not red blood cells, which would make my differential even more different. But I would think about some vascularity still. It doesn't look like there was any concentric narrowing on some of the blood vessels, which is sort of more what you expect. Just throwing it out there, I don't think this is what's going on necessarily, but CNS vasculitis is always something we get called and asked about. And there can be very super variable imaging findings or none. So in those cases, we really do rely on brain biopsies and LPs and stuff to help guide us in terms of whether we think something inflammatory is underlying or not. But I kept talking and I didn't let you answer. Do we have did you get a full urine protein count 24 hours?
So we did a urine protein creatinine ratio, which was actually elevated at 0.79.
Okay.
And then I know that you earlier asked for the APLS labs, which were negative. So that's like the cardiolipin, lupus anticoagulant, and beta-2 glycoprotein.
Yeah, and Dr. Dua, I'd love to learn from you about, you are drawing this connection between we have some concern for hypercoagulability, and then the setting of these cytopenias and potentially this like worsening kidney injury. Like how, if at all, can those two things be related? I'd also love to get some of your thoughts on, do we think that these are all tied together in this patient? Are you still thinking of these things as like separate? So I'd love to hear from you about that.
Yeah, I mean, some people are splitters and some are lumpers. Of course, I think, it's great when everything makes sense under one diagnostic umbrella, but it doesn't always work that way. I think, I do think there's probably a relationship here with these cytopenias and this kidney bump. Of course, the creatinine could have worsened because her hypertension is worse, or, any of the dryness or any other reasons for her creatinine bumping. But the proteinuria is questionable. She had negative APLs. You can get like TMA of the kidneys, and that can lead to some proteinuria, but you can also get other types of renal involvement from lupus that can cause, more of a pure proteinuria picture, like a class 5 or something like that. And that would also tie in with some of the cytopenias you're seeing here. So that would be something to consider. Like I said, with CNS like vasculitis or secondary vasculitides, there are some that can affect the brain. This does seem less likely. Usually you can get, like with CNS vasculitis, you kind of get a stepwise decline. She's a little bit older than your typical demographic, and she's a female. Not that everyone follows the textbook, but when we're just trying to tease some of that stuff out, it's still a possibility. We tend to not really see as elevated like SED rates when we have somebody with CNS vasculitis, and you kind of get this, like I said, a stepwise decline sometimes with recurrent strokes. But the MRA imaging was not very suggestive. Again, if that was high on your differential, then you would really need to like actually do the LP, get a biopsy or something like that. But also that wouldn't explain very well these cytopenias, because you don't tend to see this other sort of involvement, and it wouldn't tie in with the renal issues.
Absolutely. So what, I keep coming back to you about lab, about what next steps for lab, but I'm calling you from the general medicine world and saying, what kind of rheumatologic workup should I send in addition to what I heard an LP from Dr. Dua, but anything else that you're looking for?
Absolutely. So I think at this point, just like Dr. Dua was saying, the thing that really comes to mind for me would be something like lupus or another sort of mixed connective tissue disease, potentially something like a vasculitis. So I think the things that I would consider sending off at this point would be, an ANA reflex, so an ANA as well as an ENA panel, as well as things like complement levels, and just kind of see where we go from there.
Sounds good. Olive, what happened next?
So we did get that ANA, which was 1 to 1280. On the panel itself, we had a double-stranded DNA that was 118. And then the IFA at this point was pending. On the panel, her RNP was elevated greater than 8. And then for her complements, her C3 was 61 and her C4 was 23.
Okay, so what do we make of some of these findings? And I think I wanted to follow up. Yusuf actually asked a very interesting question in the chat, which was what is the difference between an ANA and an ENA, given we don't have a lot of exposure to that?
Yeah, so ANA is referring to anti-nuclear antibody, and so it's more general, right? We think of that as like a screening test, with when there's high pretest probability, it can help us sort of decide whether we should go down the route of more specific testing. But there are about 1 in 5 people who have a positive ANA test that have no underlying rheumatologic disease. And it's increased frequency in people who have sort of relatives with autoimmune diseases. So that's why the joke is always around, rheumatology, consult rheumatology for a positive ANA. And that's just because it's one of those common things that it really depends a lot on the clinical presentation and why you're ordering that ANA. So ordering ANAs on people without a good clinical story for a potential rheumatologic condition can lead to a lot of anxiety for patients and a lot of downstream testing that's not required. ENA are the extractable nuclear antigens, and so those refer more specifically to some of the serologies you've tried to memorize for board exams, but they really are more specific for set autoimmune syndromes. So things like anti-RNP, like SSA, SSBs, you're ordering all of these more specific tests, basically double-stranded DNA. Those are all sort of extractable nuclear antigens, and those are the more specific things. Depending on where you're practicing, some institutions will have all of those sent off kind of in one full swath. Other ones will do an ANA, and then if that's positive, then they'll reflex it to get these ENAs. It has more to do with like the location around the nucleus and where they're getting those, where the autoantibodies are kind of like matching onto the cell from a lab perspective. But when it's translated into what's antibodies, that's the difference. And ANA is just the ANA, and then the ENAs are all the other stuff that we talk about in like lupus, scleroderma, Sjogren's, those things.
Ah, I see. That clarifies a lot of things for me. And Anu, now that the case is starting to coalesce, and we have a lot of these data points that seem to be pointing us in more of a rheumatologic direction, are there any data points from before that you're tying in now to help kind of craft the differential? And where is your differential? Where does it stand at this point?
For sure. So we have a lot of really important information that's been given to us now. And I think some of these more recent labs were certainly very, very helpful. And so when I kind of look at everything, the strongly positive ANA definitely stands out. And going into that a little bit more, one thing that used to always really confuse me about the way ANAs were reported was that I didn't really understand what the numbers themselves really meant. It's always reported as a titer. And so essentially what that second number, or the 1280 in this case, means is, it's how many times the lab had to dilute the sample before the antibody becomes undetectable. So this is pretty strongly positive. And then the double-stranded DNA is something that, can be seen pretty commonly in conditions like lupus. So that definitely piques my interest as well. I do see as well that her complements are quite low. There aren't a ton of things that will cause low complements, but something like lupus certainly would be higher on my differential with that. Complements are synthesized in the liver, and so anything that, any condition in which there's liver dysfunction certainly could cause that as well. But in this patient with normal transaminases, I think something like lupus is a bit higher on my differential. And then her RNP is elevated as well. And what I know about RNP is that this tends to be associated with things like mixed connective tissue diseases or overlap syndromes. And in conjunction with a double-stranded DNA that is positive, definitely makes me think a little bit more of something like lupus. And certainly some of the other things that we're seeing in her history would fit, things like the cytopenias, the renal dysfunction with proteinuria. So I am curious to see what a little bit more of the workup will show, but I think that's probably where I'm leaning towards most at this point.
Awesome, thank you. And Dr. Dua, anything else like from the prior data that you're tying into your differential? I'm hearing lupus as a potential for forerunner, but anything else that would modify that or would cause you to lump more than split?
No, I mean, lupus could explain a lot of these things, right? We've done, I think, pretty good due diligence in terms of ruling out like other infectious etiologies. Of course, thromboembolic phenomenon and stuff like that is important, and she's had the history of that, has been off her statin, and like I said, there could be potentially strokes happening or like a vegetation, with things flicking off into her brain. So those are all still possibilities that could be tied or not tied to lupus, right? Like a endocarditis type of picture or something like that. But these serologies are quite convincing. I mean, as Anu mentioned, the low complements, complements can either not be produced or they get consumed. And so that would lead to the alterations in the number. And those along with the double-stranded DNA are markers. And Anu pointed out some important stuff with how we interpret those lab values. I just want to make sure people know that having a low ANA or a high ANA titer doesn't mean you have less severe or more severe disease. You can have severe lupus and an ANA titer of 1 to 320, and you can have no clinical features of lupus, and for some reason it was checked and you have, an ANA titer of 1 to 2000 something. So just making sure that that's recognized, because it doesn't mean more bad disease with a higher number. And it's also not a test that we like to track over time when we're thinking about like disease activity, because it doesn't mirror the clinical disease course or any organ involvement or anything like that. We do monitor double-stranded DNA and complement levels, because those are more reflective of what's going on. So just pointing that out from a just general like lab monitoring and lab importance perspective. Other things that can cause low C4 would be like cryoglobulin vasculitis. I don't really think we need to go back through like all this stuff. Some other things in rheumatology world could cause some of these changes, but really lupus is the best fit at this point with what we're seeing.
All right, sounds good. And any other particular testing that you would want to get that you can ask Olive specifically for? Otherwise, I'll just have Olive tell us kind of what happened next in the case.
I mean, I'd probably still want to get an LP and see if there's like inflammatory fluid there. And then, there are some antibodies that are also, I don't remember if it was mentioned, but not written down, sorry. Does she have a positive Smith? Does she have a positive ribosomal P antibody? There are a couple of other antibodies that I'd probably just think about checking in this case. I'm sorry if I missed them. Olive, did you mention some of those more specifics?
I did not. I wanted to give some suspense.
Oh, okay.
Just to fill in some of the questions from the chat. We did get an echo, just went back a little bit, which the EF was 61%, and there were no PFOs. RBSP was 19 and RAP was 3. In terms of management for her at this point, we agreed. We thought like this probably sound more concerning for lupus, so she was started on hydroxychloroquine at this point, and prednisone at this point. In terms of studies that were also ordered, her Smith was ordered and that was elevated for her. Her SSA and SSB on the panel were negative. And then we also did get that LP. There was a little bit of trickiness with getting the LP because there was discussion regarding like, would she be able to tolerate that given her mental status, but we got the LP. And then other things for her, I don't know if you want me to go into the results of the LP right now or, okay, perfect. So the LP came back, her protein on there was 39, her glucose was 109, her total nucleated cells was 3. There were no oligoclonal bands, and then her gram stain from the LP was also negative. And then Dr. Dua also asked about a ribosomal protein antibody. That was 4. We got an autoimmune encephalopathy panel with the LP, and that was also normal.
Okay, so coming down to the more specific testing, I'd love to turn it over to you guys and what do you make of some of this data? And then Dr. Dua, maybe I'll have Anu comment first, and then following, like, why did you ask for a ribosomal P antibody? What is that? What is it telling us specifically? Yeah.
Yeah, Anu, why don't you go ahead and take a stab, and I'll fill in any blanks.
For sure. So, looking at the results of the LP, we see that protein is largely within the normal range, glucose also kind of there as well. There's a negative gram stain. So overall, this isn't really something that seems to be consistent with something like a bacterial meningitis. We also see that there's a total nucleated cell count of 3, which is quite low. I think less than 5 is considered normal. So that would be atypical for something like a viral process as well. She has no oligoclonal banding. And so when we look for something like that, we're looking for the presence typically of inflammation-related proteins in the CSF. And if it's positive, that can be seen in diseases like MS, as well as inflammatory conditions that affect the CNS. So things like autoimmune encephalitis, lupus, certainly if it, is affecting the CNS, and then some cerebral malignancies, to my knowledge. It's helpful that she's had an autoimmune encephalopathy panel, which was negative, because that's something that would certainly be possible given, some of the symptoms that she'd been experiencing. And then I am intrigued as well by, the fact that we got a ribosomal P antibody as well.
All right, yeah. So I agree with all of the things you guys are talking about. And when we're talking about all these serologies, I know it does sound a little bit like a laundry list that you're supposed to memorize, but they really do. We use them specifically based on like the clinical picture to help drive up or down suspicion, right, for an underlying disease. And some are specific and some are sensitive. And so like when we think about Smith and double-stranded DNA, those are more specific tests for lupus. Whereas like an ANA is not specific, right? It's sensitive. So all of those kind of play into just how we approach these blood tests in the patient. A ribosomal P antibody is a specific biomarker for lupus, but it's rare, so it's not super common. It's not sensitive, but when you do have a positive test, it's pretty specific for lupus, and it's associated with renal manifestations, CNS manifestations, especially like CNS involvement and like psychosis. So not that this patient is presenting with psychosis, but there are a lot of different, a huge range of neurologic types of involvement that can be part of lupus. That being said, there can be a lot of patients with lupus with neurologic manifestations that are not secondary to their lupus. So this is just one of those markers that can maybe help increase, again, the likelihood of a lupus patient having potentially neurologic involvement. So it's not part of like our main classification criteria for lupus, this ribosomal P. But part of that is because the test is run differently in different centers, and so it's not always super reliable. But if it's positive, then like I said, it's more specific for lupus. And so I was just wondering, with these strokes, are these strokes secondary to regular high blood pressure and holding your atorvastatin, or are these strokes secondary to inflammation causing, from your neuropsychiatric lupus, because you're going to approach those a little bit differently, right? One being lower your blood pressure, anticoagulation, make sure you're on a statin, all those types of things. And the other being, if there's an inflammatory process from lupus that's contributing to this, then you're going to use immunosuppression to try to shut it down.
Okay, so all of that kind of coalescing, it seems, on high concern for lupus and CNS involvement with the lupus. And so any like final thoughts before I ask Olive to tell us what the team came up with as the final differential and next steps for management?
I totally agree with everything that Dr. Dua said. So I think at this point, it's pretty clear that this patient, is, definitely has lupus, and she has a lot of these neurologic findings that have been going on. We've done a pretty thorough workup. And so I guess the question is this, lupus affecting the central nervous system, or is this something else?
Okay, Olive, let's hear what the next steps were and what you guys found out.
So we actually diagnosed her with neuropsychiatric systemic lupus erythematosus. Our thought process there was we did a pretty thorough workup. We ruled out an infection, we ruled out a metabolic process, and with this kind of strong history of lupus right now with pretty high Smith and high dsDNA, we felt like this was pretty concerning for neuropsychiatric lupus. In terms of treatment, we started her on immunosuppression, specifically CellSect. We actually gave her a post-dose steroids for 3 days. And just to kind of wrap things up, we also ended up following her up in clinic too to see how she was doing. I know we didn't talk a lot about her like UPCR and her urine studies, but given the concern for this possible new kidney disease and the sudden of this new diagnosis of lupus, this new diagnosis of neuropsychiatric lupus, we also reached out to the nephrology team to see if there was any discussion regarding, is this someone that we should potentially biopsy now, or should we biopsy her outpatient? And would that necessarily change the management that we were going to give her?
Wow. What an incredible case. Thank you so much for sharing really this case and also your incredible and very methodical and clear teaching from both of you from the discussion. Before I turn it over to you, the three of you, for reflections, I have a fellow rheumatologic enthusiast, Dr. Franco Murillo, who was helping with teaching points today, and I was hoping he could just give us kind of his top 3 takeaways from our case discussion, and then I'll turn it over to each of you for kind of one individual reflection that you take away from this case.
Thank you, Cara. I think that, well, the takeaway points increase and increase every time because everything was valuable. So kind of like, let's go for the top 3. So when you have CNS and altered mental status and approaching from the lens of rheum, it's always good to start broad with the mnemonic and then keep the rheumatologic conditions in the background, SLE, CNS vasculitis that actually have a stepwise decline, or autoimmune encephalitis, to name some of them. Then when thinking about rheum, when you're building your clinical construct, you need to see about the modifier, plus, minus, fever, scalp lesions, tender nerve, rash, plaques, patches, synovitis, and the patterns of them, mono, oligo, polysymmetric, asymmetric, additive, the stiffness. And then thinking about also the involvement with actual or peripheral. Then use the serologies to go up and down the probability of your clinical construct. We learn about the ANA, that is a high good pretest for good screening, but most commonly it can be positive without having any autoimmune condition. We learn about the ENA, the nuclear antigen being a most specific test. The low complement, think about SLE, liver dysfunction, cryo, endocarditis, and IgG4, pick it up from the chat. The ANA titer doesn't correlate with the severity of the disease, and it shouldn't be trended. Ribosomal P antibody increase the probability of CNS involvement in SLE, but they're not part of the criteria. And then think about cytopenias with SLE, and then also pick it up from the chat. The recurrent strokes kind of like approach with pumps, spikes, and plasma. Think about endocarditis, LV thrombus, and vasculitis, RCVS, and hypercoagulability.
Such a rich case. Thank you so much, Franco. Olive, I know you had a clinical update and a picture you wanted to show us.
So for the clinical update, we actually ended up seeing this patient and hearing more about her about a month after she left the hospital. She's doing much better on her CellCept and her steroids. She is more talkative, more interactive. Her husband mentioned that she's more able to do operational tasks and be more involved in planning, able to ambulate and walk around on her own, just kind of a 180 from the way we saw her in the hospital, which is great. And her lab work now, her double-stranded DNA actually came down to 8 from where it was while she was in the hospital. So definitely some objective data there, and her complements would basically normalize. Her C3 is now 123 and her C4 is now 34. So I think we got the right diagnosis and she's being treated appropriately. I think the big thing that I just wanted to highlight with neuropsychiatric lupus is kind of echoing what a lot of us have said already, is that you can kind of think of it as like almost like a diagnosis of exclusion, in that it can present in many different ways. And a lot of the time you kind of have to have that high clinical suspicion when you want to say that someone has neuropsychiatric lupus. And because of how it can present in so many different ways, there's a lot of discussion regarding like what is a diagnostic criteria for this? Like what should you think about in a patient that has lupus? When can you say that someone has neuropsychiatric lupus versus they have lupus and something else going on? So I did want to show a figure from our the ACR criteria or classification system, but let me see if I'm able to do that. 1 second. Okay, and I don't know if everyone can see this. So this is just a diagram that's highlighting the different possible condition that ACR in 1999 came up with, that, you know, when you're thinking of someone who has neuropsychiatric lupus, how do you kind of categorize the different possible presentations? So the way they divided these 19 conditions is via like either a central nervous system presentation or peripheral nervous system presentation. And within that, you have neurological syndromes versus psychiatric. And I think something that I've always struggled with even now with this disease process is this basically arguing that, for example, if someone said that they have depression, or, you know, they have anxiety, or we saying that then they have neuropsychiatric lupus if they have lupus. And something that has always been highlighted to me is that you really just have to have a strong clinical suspicion. You can't use this and say that this, if anyone has this and they have lupus and they have neuropsychiatric lupus, but if they're having like myelopathy and then they are also having like a really severe headache or movement disorders, and you might have to put them underneath that umbrella. And something else that's always talked about is, you know, especially a lot of the psychiatric syndromes are those syndromes that maybe occur as a result of having like a chronic illness, and that kind of affects your ability to deal with that kind of condition. But just something to highlight.
No, thank you so much for that figure. I'm always a very visual person, so it's great to be able to see that delineated out. Anu, what is your like one big takeaway from this case or reflection you'd like to share?
For sure. So one thing I'll just touch on, you know, our patient did have a pretty significant history of stroke, and, you know, her stroke history was something that played very heavily into the case. So one thing that I'll point out is that cerebral ischemia is actually the most common CNS manifestation of lupus, and patients with lupus are actually at a much higher risk of stroke compared to the general population. And this is caused by a couple of different mechanisms that I'll just quickly touch on. So the one that you really want to look out for is something like a secondary antiphospholipid syndrome, which our patient was screened for. Another is, you know, increased endothelial damage to blood vessel walls that's caused by underlying inflammation from lupus. And then another third one is actually this concept that there is advanced atherosclerosis happening at a quicker rate in patients with lupus than in the general population. And it's important to think about these things because, for example, for somebody with APLS, management strategies with things like anticoagulation would be different. So just something to think about.
Absolutely tying in that like initial chief concern and like how it modifies our thinking throughout the case. Thank you, Anu. And then rounding it out, Dr. Dua, any big takeaways you have for us?
No, my fellows are awesome. You guys are awesome. Rheumatology is interesting. You should all do it. Honestly, with this case, I think it's like a lot of the stuff that we see, we're always kind of, I think it just really highlights the crossover with other fields, you know, and so we're always kind of working with neurology, with cardiology, with pulmonary, with ID, with internal medicine. And so that's what keeps rheumatology fun, with renal. And just from this case, you can kind of see how much, you know, we depend on some of these other consultants to like help rule in or rule out diagnoses. And honestly, the real thing would be just, you know, think about your pretest probability when you're ordering some of these tests, and that really will help you figure out how useful they are and where they should, how they should be weighted when you're like trying to navigate potential clinical syndromes and like putting labels on people. It's really hard to lose labels once they're given for patients. And so I just think it's important to really do your due diligence in terms of figuring out really what's going on before sort of throwing in the towel. And a lot of that has to do with your pretest probability. So
That's it. Thank you. I've often heard, yeah, to be a good rheumatologist, you must be a good internist first. And
yes.
so I want to thank the three of you so much for your insights, your teaching, and your enthusiasm. You are what make this report amazing. And I hope to see all of you soon in the next one. Take care, everybody.
Thank you.